Bismillahirrahmanirrahim. Okay, so students, today we are going to discuss a very important topic of IMM, that is the male factors of fertility. So today we will talk about the semen analysis results and the further management. Okay, so it's very important that in the fertility treatment, the first thing of both partner is the male partner semen analysis, because that is just one test. The female has to undergo a lot of tests. So the rules say that first thing you have to do is to do the husband semen analysis, and that's the female's investigation. So please keep this in mind, okay? Now, so if the result of the first semen analysis has a gross issue, for example, it has a gross sperm deficiency, azoospermia, or severe oligo that is less than 5 million, then you have to repeat it as soon as possible. Otherwise, with any other abnormality, always have to repeat it after 3 months. What I mean is that when there is one abnormality in the analysis, then you are supposed to repeat it. But now it depends whether you are going to repeat it as soon as possible, okay, or you are going to repeat it after 3 months. So if there is a gross issue, for example, azoospermia, or there is a severe oligo, then in these scenarios, you are going to repeat it as soon as possible. You're not going to wait for 3 months. Otherwise, you are going to wait for 3 months, ask the patient to wait for 3 months, and then you are going to repeat it, okay? Now, let's just talk about severe oligospermia when the sperm count is less than 5 million, and the treatment for this is the intracytoplasmic sperm injection in the egg, that is ICSI. Okay, and then we have the moderate, in which the count is between, you have to memorize this, 5 to 10. Less than 5 is severe. If they ask you at 5 million, that is not severe, that is moderate. So the treatment will be changed. The treatment for moderate is IVF. So you have to remember that for less than 5 million, the treatment is ICSI, because the category is changed, that is severe. Okay, but for 5 to 10, it is IVF, because the category is moderate. Now, mild oligospermia is between 10 to 15 million, you have to wait. Now, total mortality is 40%, progressive is 32. You have to memorize these 2 points. Now, one very important thing is that the subfertility factors. It's a very important question. That if there are severe factors of subfertility, for example, if there is severe oligospermia alone, that is the sperm count is less than 5 million, or severe asthenospermia, or if there is a combination of 3 subfertility factors, then in this whole scenario, this is known as severe male factor subfertility, and the treatment is going to be ICSI. Please memorize this point, okay? Any three factors or one severe factor, for example, severe oligospermia, then the treatment is going to be ICSI. Otherwise, when it's moderate, for example, if there are 2 factors, then in that case, the treatment is going to be IVF, okay? So, now we know that when are you going to repeat the analysis in 3 months, and when are you going to repeat the analysis urgently. This is a scenario you should know, that when to repeat it urgently and when to repeat it in 3 months. Okay, very important point. Now you know the definition of severe male factor infertility, and the treatment is going to be ICSI definitely. For mild male factor infertility, it's going to be IVF. What is the example of this? Can anyone tell me the levels? Mild oligo or moderate oligo? It's moderate oligo, okay? Moderate oligo is 5 to 10 million, and the treatment is IVF. So it's the issue is with terminologies. So you have to revise this so that you don't confuse them, okay? So for mild oligospermia, when the count is between 10 to 15, you are going to do expectant management. You are going to ask the patient to wait. But when it's moderate, between 5 to 10 million, then this is mild oligospermia equals to mild male factor subfertility. I know this is confusing, but when you revise it, you will get used to it, okay? So now this was the basic algorithm. Now what to do when you have azoospermia? In azoospermia, you first test, you're going to pick serum FSH and then testosterone. Never pick testosterone as first line. Now we have the whole algorithm based on the levels of FSH and testosterone. So if both are normal, both of the hormones, then this means that there is an anatomical obstruction, okay? Some obstructive azoospermia. So in obstructive azoospermia, you have to refer to a urologist or do an ultrasound. So if both options are present in the question, I'm teaching you guys for the IMM exam, okay? Then we have to pick urologist over ultrasound. Refer to urologist greater than ultrasound. Always remember this. Okay. So, what is the next step? The next step is going to be referral to urologist. If that option is not present, then the next step is going to be ultrasound. So on the ultrasound, the vast difference, if they are absent, then you have to screen for cystic fibrosis by karyotyping. Okay, and if you find absent testes, then again you have to refer to your urologist. If there's a mass or tumor, then again you have to refer to urologist. So the absolute treatment of obstructive azoospermia is sperm aspiration and ICSI. Okay. Now FSH is low. Now both of them are low. So we have done one scenario, and when both of the hormone levels, FSH and testosterone, are normal. Next scenario is when both of them are low. So when both of them are low, then this is hypogonadotrophic hypogonadism, and the issue is definitely Kalman syndrome. And we're going to treat with pulsatile GnRH. Very simple. Now, FSH is high and testosterone is normal, and the other scenario is that FSH is high and testosterone is low. FSH is high and testosterone is normal. This is a failure of spermatogenesis. And in this scenario, you have to do a biopsy. And then if any sperms you are able to find out, then you have to do ICSI. This is very important. When the arrows are like this and this, which one is high, the other is low, in the opposite direction. Just memorize it like that. This is complete testicular failure. And the scenario which leads to these things, the options are going to be Klinefelter syndrome, that is 47XXY, Noonan syndrome. Noonan syndrome is also known as the male Turner for XY, and also X naught. It's 46 X naught. There's a typing error. And Y microdeletion. So always remember this. Okay. Now, this is an MCQ point that 37% of total infertility is from the male factor infertility, and 66% of the testicular failure is idiopathic. Okay. So this was it. So can anyone please tell me that what is the next thing? If one semen analysis gives you azoospermia, what is the next step? The next step is urgently repeat it. Okay. One more question I'm going to ask you, that if one analysis gives you, let's say, a decreased motility, that is, let's say it's 25%. Now, what is the next step? You're going to repeat it after 3 months. Okay. So this is the basic concept. First of all, the first thing in male factor subfertility, the number one that you should know is that the first investigation of both partners, you have to do the investigation of the male partner, you have to do the HSA before going on towards the female partner. Number one. So that's why you should learn this first and then learn the female investigation, because this is the first thing that you're going to do. And then you should know what happens when there are abnormal results, when to repeat it urgently, when to repeat it after 3 months, and what is severe, mild, and moderate oligospermia, and what are the management options, and then what is severe and mild male factors of fertility. These two things are different, okay? And then what happens when you have azoospermia, you have repeated again azoospermia, you're going to do FSH, then testosterone, and then depending on their levels, you're going to manage, okay? So this was just a short discussion on the subfertility topic that we have started for the IMM exam. Thank you, guys.